Hello, and welcome back to another JOP podcast from ASCO. This is Dr. Bob Miller, medical oncologist at Johns Hopkins and consultant editor at the JOP. I'm sure many of us still recall how exciting it was in 2010 when Kwok et al. Published a paper in the New England Journal showing that patients with advanced non-small cell lung cancer who had rearrangements of the ALK gene derived substantial benefit from the drug Crizotinib. I think the overall response rate was 57%. You know, I did my fellowship in oncology in the late 1980s, and I still think it's remarkable how in 2012 we can identify driver mutations in a significant number of lung cancer patients and offer them targeted agents with a meaningful chance of response and possibly even improve survival. But what really happens between the time a new agent is approved and when its use becomes commonplace and predictable? Well, in the May JOP, my guest for today's podcast, Dr. Nathan Pennell of the Cleveland Clinic, tells an interesting story of his experiences with prescribing Crizotinib shortly after its approval by the FDA in August 2011. As you'll hear, there definitely can be some bumps in the road. Dr. Pennell is a medical oncologist and assistant professor of medicine at the Cleveland Clinic Taussig Cancer Institute. He is a clinical investigator who conducts clinical and translational lung cancer research and serves as director of the Cleveland Clinic Lung Cancer Medical Oncology Program. Thanks for joining me, Nate.
Thanks for inviting me, Bob. I appreciate this opportunity to talk about the article.
So let's get the important stuff out of the way first. How do you pronounce the trade name for Crizotinib?
I believe it's pronounced Xalkori. The middle three letters are ALK, so they had to work that into the name somehow.
You know, I don't think I realized that. Very good. That's very clever. Okay, so after, we'll say Crizotinib, because I know I can pronounce that. So after Crizotinib was approved, what were some of the logistical and administrative issues that I think you anticipated about its prescription and use?
Well, I had been participating in the registration phase 3 trial as well as the phase 2 trial here at the Cleveland Clinic. And so we had been sort of seeing the approval coming down the road. And because this was going to be likely approved in such a limited number of patients who were going to be defined by a specific molecular test, that just worried me a little bit because that was a little more complicated than insurance companies are usually used to dealing with. And I was certain, although at the time we didn't know how expensive it was going to be, that this was going to be a very expensive medication. Sure. So I knew at the very least there were going to be some logistical hoops to jump through in order to get insurance approval for coverage of this. What worried me a little bit more was I was giving a lung cancer educational talk to a group of insurance adjusters at Blue Cross and Blue Shield in South Carolina, and I was talking about the upcoming story of ALK and Crizotinib. And after the talk, the manager of that particular branch came up to me and was just very worried about all of these new medicines that were coming out with these new tests, and he seemed completely overwhelmed with the technology and the medicine behind this, and really wasn't sure how his company was going to be able to learn who they should be and shouldn't be prescribing. And so considering that's one of the largest insurers in the country, I figured that perhaps this was something more to worry about than what I was originally thinking.
That doesn't sound very reassuring.
No, definitely not. And something I didn't learn until after it was approved, but makes perfect sense. Since there's never any guarantee of approval right until the moment the FDA does it, the companies don't go into large-scale production of their drug until they actually get that approval. And so at the time that the approval comes through, they have a really limited supply of the drug, usually what was already made for their research studies. And then, of course, they try to ramp it up relatively quickly. Mm-hmm. Because this is only going to apply to about 4 or 5% of lung cancer patients in the United States, perhaps 3,000 to 5,000 patients a year, you would think it wouldn't be a huge issue because probably within a month they could ramp supply up. But in that period in between, there's clearly a bottleneck.
So why don't you tell us the story about the 3 patients that you talk about in your JOP Perspectives article?
Okay. So we had been getting referrals for patients with ALK positive lung cancer because we were the closest academic center that had the trial open in northeastern Ohio. And so it wasn't that unusual that I was seeing a number of these patients. The first patient that I saw was a 35-year-old young man, never had smoked, and had gotten a chemotherapy for his metastatic adenocarcinoma of the lung, but unfortunately had rapidly progressed through that chemotherapy, which is a very poor prognostic sign. He was becoming quite symptomatic. He was short of breath. He was coughing, and came to me when his local oncologist had done a test by something called polymerase chain reaction, or PCR, that identified the ALK fusion gene product. So he was referred to us because they knew we were running this trial. This was, I think, in mid-August of 2011. The original trial had required that the ALK translocation be identified by fluorescence in situ hybridization, or FISH testing, which is currently the FDA-approved test for ALK translocations. However, this particular patient had had a different test that identified him, and there were a number of different tests being used to identify these patients prior to the approval, including RT-PCR. That wasn't really a problem because the company had amended their protocol and they were allowing ALK-positive patients essentially from any test to be enrolled on the trial. But it required an extra step. You had to get the test results, you had to submit it to the company, you had to wait for approval. So we were sort of in that process when August 26th rolled around and the drug was approved. And anyone who had signed consent for the protocol, unfortunately, was no longer allowed to enroll. So he missed the cutoff by probably less than a week. So we were in the position, since the approval came in on a Friday night, on that Monday morning, essentially 3 days later, trying to get a prescription for this drug. And what we discovered when we called his insurer was that the person on the other end of the phone had no idea, he'd never heard of the drug, had no idea what was going on with it. And so we submitted our request, and then we just waited and heard nothing. And after this experience, we became much more aggressive about following up and calling. But at least initially, we just assumed that someone would know what was going on, and about a week passed without really hearing anything. We called back. They still hadn't really heard much of anything. I asked if I could speak to a physician there, and they said until they'd really officially denied it, we couldn't really talk to anyone about that. Finally, I ended up calling the company, Pfizer, who makes the drug, who was very helpful. And they actually had been in contact with all the major insurers and had a very quick inroad into these things. And so in retrospect, that probably ended up being a better initial way to go than trying to go through the front lines of the company. They did eventually approve the drug, and it was shipped to the patient, although practically in business days it was about 2 weeks later, which was tough because this is a patient that was symptomatic, and normally I would have just started chemotherapy quite rapidly on him given his symptoms. So I was getting worried as the days were ticking by. The second patient actually is probably the most remarkable patient story I've experienced in my relatively short practicing life. It was a young man who actually has broadcast his story in newspapers and whatnot, so he doesn't mind me talking about him. It was a 24-year-old medical student who had noticed some lymph nodes in his neck. On scan, was convinced that he had Hodgkin's disease, as was his local doctor, because of the mediastinal mass, and had never smoked. Had a biopsy and unfortunately showed adenocarcinoma of the lung.
Wow.
Was referred to me the week prior to the approval of Crizotinib, and I was convinced, just looking at him, that he either had an ALK translocation or an EGFR mutation, just given how young and the fact that he'd never smoked. So we sent that off for testing. He was pretty healthy and didn't have a lot of symptoms at the time. And just in case, we set up starting chemotherapy for the following week because he really didn't want to wait for the testing to come back. When he showed up the next week, which coincidentally was actually the day of the approval of Crizotinib, he looked terrible. He was a little bit blue. He couldn't really breathe. We admitted him directly to the hospital, and then within 24 hours was admitted to the ICU in pericardial tamponade. had a pericardial drain placed. He had developed large bilateral malignant effusions just in the period of a week. I mean, very aggressive disease, and was briefly intubated. And during this time, we were trying to expedite the testing for his ALK, translocation and EGFR mutation. Probably close to a week after his admission to the ICU, we finally got the results, and he was strongly positive for the ALK translocation. He had already gotten one dose of chemotherapy, which was unlikely to be helpful, and we couldn't even get his chest tubes out because of the level of drainage. So at that point, we tried to get the drug approved. We'd had a little experience from the prior week with the first patient, and so I was much more aggressive about trying to get follow-up on this. The company had heard of the drug, but it was very expensive, and this was an unanticipated problem. The drug was initially only approved to be shipped from one of 3 mail-order pharmacies, specialty pharmacies, and the patient's insurance company had a specialty pharmacy, but it wasn't one of the 3 that was approved to initially carry the drug. And the insurer had a special deal with their pharmacy, so they weren't willing to have the drug shipped from a pharmacy outside of the one that they normally used. And so it was kind of a very strange runaround that we were getting from that.
Real catch-22. I mean, if you have to use one pharmacy and they don't know anything about the drug, that's a big problem.
It was, and it's one of these things where you just try to beat your head against the wall, and the people on the other side of the phone just didn't seem to understand what the problem was. But this is a situation where Pfizer, again, was enormously helpful, and they communicated with the company, and I'm trying to imagine what it would have been like if you'd been at a small oncology office somewhere where you have perhaps one staffer who normally handles this stuff. Although here it probably only took a couple of days. One of those days was pretty much a full-time, about 12-hour period of one of our financial analysts working on the phone with the pharmacy, with the other specialty pharmacy, with Pfizer, and with the insurance company. It would have been very difficult to have that done if you didn't have the resources available to do that.
And you were the clinician. You're taking care of this critically ill young man, just waiting for this sort of administrative stuff to play out.
Oh, it was. And this is a situation where, he could have had a horrible outcome at any time. And we really were trying to get this done as quickly as possible because I had personally seen how quickly patients could respond to this drug. So the good news is, before we left on the following week after the approval, on that Friday night, it had been promised that it was going to be shipped to us. And I think one of the most remarkable things about this was I was home about 10 o'clock at night, and on my cell phone, for some reason, I have no idea how he got my cell phone number, but I got a call from the head of medical affairs at Pfizer who had heard that this was going on through the grapevine and actually offered us to be able to use the drug that was sitting in our research pharmacy at the cancer center, and because he'd heard that this patient was in very serious condition and really needed to get treated right away. Now, this would have been nice to maybe have known a little bit earlier, but better late than never. I actually really appreciated that offer. Fortunately, the drug that had been approved arrived first thing the next morning in the ICU, and the patient started on it. Remarkably, was clinically improving within 2 days of starting on the drug, and I think 11 or 12 days after starting the drug, actually left the hospital on his own 2 feet.
Wow.
Having most of his symptoms resolved. His lymph nodes already palpably smaller. It was quite remarkable.
That's amazing.
The third one actually was the one I was the most worried about, having lived through the first 2. This is another young man who'd never smoked, who this time had the approved ALK test done and was referred to me. I don't think they realized at that time that the trial had been closed, and was not symptomatic, another very healthy guy. This was, I believe, the second week of September, so we'd just gone through the second patient, and then we'd gotten the approval for the first patient at about the same time as the second patient's approval. And so we tried it again, and this time I knew which financial adjuster to go to because he had called all the right people. I immediately put my call into Pfizer just in case that would help. And turns out that by this time, the patient's insurer approved it, They had even a form in place where you could check off for the box for ALK positive testing, and the patient was shipped from one of the specialty pharmacies the drug 48 hours later. And I believe his copay was he told me it was something like $70. So it's actually a relatively short window of time, I believe, where these problems come up. It just happened to be my bad luck that it all happened at the same time.
So these cases it sounds like these cases were just within a few weeks of each other then.
They were. I think, the first patient we'd been dealing with for a couple of weeks before this started while we were trying to enroll him on the trial. But the period of prescribing the drugs was actually within a 2-week period for all three of them, between the first 2 weeks after the approval.
And have you seen anything comparable in the last year now since the drug's been out? Are things a lot smoother these days?
Things are much smoother now. I've never had anyone having trouble getting the drug. It is quite expensive, and they do have a copay assistance program in place because even if you have a 20% copay on a $10,000 a month drug, that's a significant financial burden. But in terms of getting approval for the drug, the insurance companies seem to finally be on board with this.
Let's go back to talk about what you mentioned earlier, that this is a case where, if I'm understanding this correctly, the FDA required a specific genetic test to be positive for eligibility for the drug. So can you talk about your feelings about that, and how should exceptions really be handled to that?
Well, it's a good question. I think, as far as I know, this is the first oncology drug where there has been an approved companion diagnostic that goes along with this. For example, for breast cancer, for the drug Herceptin, for HER2-positive patients, I'm not aware that there's any specific approved test for determining someone is HER2-positive to get approval for the drug. And the company very carefully worked with Abbott Labs to develop this break-apart fish assay and validate it and make sure that it was accurate, and submitted their application at the time of the approval for the Crizotinib for the companion diagnostic, which in their defense was also very rapidly rolled out. And within a week, I believe, of the approval, our CLIA-certified lab, had already gotten the approved probes and was doing the fish. And so it really wasn't a huge issue. The problem on my end was I had seen a number of patients who had been negative by the fish test, but had been turning up positive by other assays, and based on the trial, were allowed to enroll on the trial, and some of them were actually clearly benefiting from the drug, despite having a negative fish assay. And that just set off a little bug in my ear about whether or not we should be restricting this drug to people who are approved based just on the approved test. Now, I completely sympathize with the FDA and insurers wanting to limit the patient population for this drug. It is quite expensive, and there's really no reason to believe that it's going to be effective in anyone who doesn't have the gene translocation. But at the same time, you don't want to restrict it, or at least you don't want to deny this drug to someone who might benefit from it just because they don't have a specific test. Mm-hmm. So what I hope will happen is, as new tests are coming out, and I believe that, for example, immunohistochemical staining for ALK is looking very promising. I don't know if it's been published yet, so I don't want to give any details, but I wouldn't be surprised if it's going to be comparable efficacy to the ALK fish, but it's not going to be an FDA-approved test. So I'm not sure how insurers are going to handle that. What I hope, if the scientific community comes together and agrees that there are other tests that are as accurate as the break-apart fish assay, that insurers will be willing to cover that. But to be honest, I'm not sure how that's going to pan out.
So do you know right now, is the break-apart fish required for insurance companies to release the drug? I mean, is that sort of the assumption that you're going to have the positive fish before you get the drug, period, and everything else is an exception?
As far as I understand, that is the way the insurers are writing their policy right now. I was having this conversation with some of the Pfizer people while we were working with these three patients, and as they were working with insurance companies to develop their policies, that was the official policy. And, you had to have a positive test on the FDA-approved assay. That's on the label, actually, of the drug, that's the approval. And so insurers, I believe, are legally allowed to limit their approval to those patients. What I can tell you is, from a practical standpoint, I believe that insurers will be more flexible than that, but it will probably require an extra step of an appeal, at least initially, until other tests become widely accepted.
So it sounds like you had a pretty good experience with Pfizer, although, in the perfect world, hopefully you would not have to go through all those things. But what kind of advice do you have for pharma companies that if they're about to release a drug like this, and there's some questions about supply, what would you tell them if you were in a position to do that?
Well, a lot of what I would suggest actually was happening, but it wasn't really widely known. So obviously the companies need to work with the insurers to develop the policy for what should be approved based upon an assay, because more and more of these drugs are going to be coming out that are only going to be approved in specific subgroups of patients. And I think, again, the window of time where they're really going to need to be keeping track of their drug supply is probably in the range of a month after the approval. But during that time, what I would suggest is when they roll out the approval that there be a central number, an 800 number for the company that would potentially be the first call of someone who wants to prescribe this drug, because the company itself has the inroads into all of the major insurers to get these things done, but this hasn't necessarily filtered down to the person on the front line at each of the insurers. They may not yet have heard about these changes, and we got much more traction going through Pfizer, who then contacted the insurers directly, than the other way around. So I think a central call center from the company itself to kind of handle the logistics initially. And the other thing, of course, the company knows where their drug supplies are and could potentially be willing to iron out any of the problems with shipping or specialty pharmacy coverage, or even potentially use of the research supply in situations where the clinical situation required a quick turnaround.
Well, let's hope they're listening to our podcast.
Yeah, I hope so too.
So, Nate, it sounds like it's an exciting time to be a lung cancer oncologist these days. I mean, there's a few targeted agents available now. One of them, obviously, this, and things in the pipeline. Look into your crystal ball, and what do you think the short-term future is going to hold for the treatment of advanced non-small cell lung cancer for the next couple of years?
Well, I think in the next couple of years, I don't know if we're going to see any Crizotinib-like drugs approved for widespread use, but we are already seeing an enormous number of drugs in earlier development. So if we were to take that out maybe 5 to 7 years, I think we're going to see a lot of more of these molecularly targeted drugs in lung cancer. Probably the best example of something that's going to impact patients in the next couple of years is something called ROS, ROS, which is a different gene translocation. It's a tyrosine kinase very similar to ALK that Crizotinib appears to also be able to inhibit. And this has been discovered in about 1 to 2% of lung cancer patients, so maybe half as common as the ALK translocated lung cancer. It was just presented at the ASCO meeting earlier this month. And about 15 patients in Boston who had this ROS translocation were treated with Crizotinib with a very similar response rate to patients with ALK who'd been treated with Crizotinib. So this is something that can also be tested for with a break-apart FISH assay and may immediately open up a new population of patients to this already approved drug once the test is more widely available. Also presented at this last month's ASCO was the discovery that another perhaps 1% of patients have translocations in RET, R-E-T, which up to now has been commonly seen in thyroid cancer,
right,
but is present in lung cancer. And there are already drugs out there approved, such as Vandetanib, which is approved for medullary thyroid cancer, that may be active in these patients, although that is so early that we don't yet know how effective it will be in patients. But I wouldn't be surprised if, within a couple of years, this is something we can test for and potentially treat patients with. We already have known that somewhere between 2 and 4% of lung cancer patients have BRAF mutations. And of course, the melanoma world is familiar with BRAF mutations and the new drug vemurafenib, which is approved for those patients that may end up being effective in lung cancer patients. So there's a few of these that are already out there that we might be able to have in the next couple of years. Over the next 5 to 7 years, there's a lot of potential with drugs in KRAS mutant lung cancer, which makes up about 20% of lung cancer patients, and inhibitors of the downstream pathways such as MEK appear to be, at this year's ASCO, again, some trials that appear very promising. A lot of progress is being made in the ALK translocation patients and in the EGFR mutant patients after they've progressed and developed resistance to their targeted therapies. So I think we're going to be seeing better second-generation inhibitors of these that are going to be hopefully better than the existing drugs coming out in the next few years. So I think it is a very exciting world. We need to keep slicing our pie of lung cancer and identifying these subgroups of patients that benefit from these drugs. And hopefully, before too long, we won't have a situation where we just have to give chemotherapy and kind of cross our fingers and hope that it's going to work. You know, one other thing that I want, and this is kind of a message I'm trying to get out there now, is that all of these targets that I've been talking about and a bunch more, there are already drugs in trials at centers around the United States and internationally that are being tested in these patients. And so for the first time, probably in the history of oncology, phase 1 trials and early phase trials in these molecularly targeted subpopulations have a real chance of clinical benefit, and that's not the way it's always been in the past. So especially in non-smokers who have lung cancer, I'm strongly recommending patients refer their patients who have, especially light smokers or never smokers, to an academic center to have their cancers molecularly tested for a lot of these new targets, because I don't want any of these patients who are here in this next 5 to 7 years who could be benefiting from these drugs now to miss that window.
Well, it's been very interesting talking to you about your experiences with this, and thanks so much for sharing your insights.
You're very welcome, Bob. Thanks for inviting me.
And thanks again to all of our JOP podcast listeners and JOP readers for your interest in our work in the journal. Don't forget, there were actually 2 JOP issues in May, including a special supplement on payer-provider relationships in oncology, where Dr. Pennell's perspective piece was found. So we would love to hear from you as well. Drop us a line at jopeditorsdesk@asco.org or make a comment on the JOP page on iTunes. We'll be back next month with another podcast from the July issue. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thanks very much for listening.